So we have some time for questions. Take them from the audience here.
Does it work? Can you hear me? Janet, thanks for being so prophetic. But I'm going to first give references and then say something. But the references are Ron Howard did a film for National Geographic, The Age of Aging. And also, what I'm going to tell you, Ned Sharpless is a very strong advocate. But what we've done as scientists, we came together 2-3 years ago. And exactly what you said, word by word, we planned a study. The study is called Taming or Targeting Aging with Metformin. And our primary endpoints are cardiovascular plus Alzheimer, MCI plus cancer plus death. We went to the FDA, we had meetings with them, we talked about repurposing this drug, we talked about what can we do now so that you don't come at the end and say you should have done something else. And this study is going to start in the next several months. We actually have some support from the NIA and some support from other things. So what you've said is actually, we couldn't wait, the scientists, we want to implement it, and we're doing it right with the words that you were saying. I just want to say, the biggest obstacle for us with the FDA was that we at aging are agnostic to the diseases. Okay, every one of those diseases has a biology of aging background. The aging drives the disease. So for us, it doesn't matter what disease you have and what you get. It's all aging, so we can cluster it together. And we don't need 12,000 people. We need 3,000 people to do that. So thanks for saying the same thing without knowing.
Well, I'm glad you're doing that trial. We do have similar situations elsewhere. For example, the Oncology Center of Excellence in Cedar, we've approved a number of oncology drugs for tissue-agnostic indications. And this is what does this mean for those of you who aren't this means it isn't for colon cancer, it isn't for breast cancer, it isn't for this kind of cancer. It's for cancer that has a specific biomarker that means it's amenable to the intervention, right? So this has the same cognitive dissonance to those who are used to studying cancers by histologic type, as what you're saying, that for aging. Your aging in itself, of course, is both a natural phenomenon and can be partly pathological. And I think we have to go a long way in sorting those things out. Yeah, but we're up to it. Thank you.
I know that this is a controversial question, Nir, and I'm fascinated to hear the answer of Richard and Janet on this. What do you think of the idea of treating aging as a disease?
Well, I think if by treating aging we're talking about trying to prevent the adverse consequences of aging, then I think that's very parallel to disease. And I think the notion of treating underlying pathways, age-associated pathways that predispose to or cause disease is eminently logical and reasonable.
Right, and I just said age is both a natural phenomenon, aging, and it can have pathological consequences. And so it's really the pathological issues that we're talking about, not the fact I would resent that as a senior citizen myself.
Gordon Cutler. I'm an endocrinologist, and I heard at the Endocrine Society just either in the last year or two about the senescent cell development. And I wondered how much is known in humans about whether either looking at immune cells or other easily available cells, how well do the older people who seem healthy have fewer of these in humans, and are there certain behaviors, certain diets, and other things that affect the development of senescent cells, other than the drug idea of trying to kill them?
in terms of correlations, still a lot more work to be done in humans, to be sure, but there have been studies looking at a variety of hematopoietic, non-hematopoietic tissues, quantitating the percent of cells that meet criteria for senescence phenotype, age, young versus old, and shown significant increases in the numbers of these cells. I think there's still a lot more to be done in terms of even the initial correlative epidemiology about the degree to which changes over time in senescent cells correlate with particular pathologies, lifestyle, debilities, diseases. But I think those studies are going to come very quickly. You know, quite remarkable the technologies we have to do this now, if you think about it. And this is some of the thoughts we're having at NIH most recently, and this is really quite emerging science. If we can identify a senescent cell by its molecular phenotype, by gene expression, by secretory phenotype, with what's happening these days in terms of single-cell omics, single-cell gene expression, transcriptomics, metabolomics, et cetera, it means in many of the studies that are already going on in humans, in disease or normal conditions, multiple tissues being sampled, growing database. So we're engaged in conversations with colleagues across the institutes at NIH. If we could simply begin to accumulate the information on cells from various tissues, various people, which is being collected for other reasons, and coordinate these in such a ways that we can identify senescence as a phenotype, we should be able to address the questions you're asking in a relatively comprehensive way. And it may even be that then some of the interventions that are happening, even if they were not intended to be targeting senescent cells, may have an impact on senescent cells. We can learn still more that way, all to inform the direct interventions that are being planned.
There's an interesting correlate with the immune system. As we get older, that kind of memory, you go in to get your annual seasonal influenza vaccination after age 65, and you need a stronger stimulus to achieve the same outcome, even though your life experience with encountering immunization or the natural virus has been ever greater. So as Richard was saying, there are other organ systems that also have some version of memory that is profound, that are much more amenable to those types of single-cell studies. Questions from over here?
Yeah. Janet, I was really happy that you narrowed in, or you honed in on what I think the key issue is for this whole space, which is endpoints for trials. And I think that you also correctly identified that the first endpoints are going to be composite of multiple things that we can measure now, like what NIR is measuring in this TAME trial, heart disease plus cancer plus death. But I work to invest in and develop drugs in this space, and one of the big issues facing us from the perspective of new chemical entities, things that aren't already approved and used in humans, is the time that it will take for these trials, right? By the time you go through a phase 1, phase 2, phase 3, there's almost no patent life left on the drugs that you've registered at the beginning of the trial. So do you see one or two initial trials measuring these concrete endpoints as a bridge to creating a biomarker, a composite biomarker that could be based on some of these like metabolomic things, or some kind of what I call a multimorbidity risk index that you could then use as an endpoint later on?
Honestly, I don't think it's likely in the near future because we don't have enough science to connect these things. And I'm not sure, to Zan's point, all this consumers and everybody on the other end, you know, I don't know how compelling that would be to a clinician or a patient to commit themselves to a lifetime of intervention based on their biomarkers. It's possible far enough along if we understand things better. What I was proposing is that we talk about things and make endpoints things that people really care about. They may also be more amenable to, there may be larger event rates of those things than there are of actual hard cardiovascular outcomes and so on. But decline, what people fear in aging, they fear decline in physical functioning. They fear decline in mental acuity. They fear being put in a nursing home, right? They fear being put in the hospital. They've told us this over and over again. These things could be measured and could be actually very sensitive. You wouldn't need to improve them, you could stabilize them, although Richard showed some interventions that improved these things, simple interventions, right? Exercise, cognitive training.
Okay, thank you.
Good morning. This is Vaman, a scientist turned into entrepreneur. I thoroughly enjoyed both of your talks. I come from the extreme right, from the Zan's first slide. I figured out that we are doing great science, a lot of innovations in each of the fields. Kudos to all of us and all of you. But the real problem we see on the ground is the innovations. Despite all these innovations, the last mile reaching to the consumer is not right. That's a big valley. So that's a problem, not only costing the health outcomes, increase hospitalizations, but more importantly, making healthcare unsustainable. I go back to Richard's slide. He has shown we already are at the convergence point where the aging population is increasing, effective today. The cost on a global basis is going to be $9 trillion as of this year. By 2022, it'll be $10 trillion. It's not going to be sustainable. So fortunately, we have been looking into it for the past 5 years. Because of my personal reasons as a caregiver, I got involved into that. Otherwise, like all the fellow participants here, I was also involved in discovery, new technologies, approvals, and whatnot. So starting from the extreme right, over the past 5 years, we have designed and developed an innovative system of care delivery that's absolutely consumer-centric. So we reimagine the processes, we reimagine the medical clinical service flows in such a way that we are able to deliver a hassle-free service 24/7 when, how, where consumer gets it. And it's both service continuity, whether it's digital on demand or in person. As a part of this, we will have approximately 300,000 patients or individuals, consumers, with general to worried well to all the way to extreme chronic, both in Toronto and in Boston area. So we have decided to do, as a part of this, a study. When we do annual checkup, we would evaluate mental, physical, clinical, and wellness as a part of it, and put into not just medical record, Janet, as you were saying, also create that personal health record, so the system, service moves with the patient, individual, and information moves with the patient. It's like a passport. So having said that, is there any guidance you can give us in terms of setting up that as a study, what outcomes we can measure? And of course, Anne is part of my colleague. We have been working on this project for the past 5 years. So would love to hear your thoughts. Thank you.
Well, I believe these types of networks are the future of the, I think the current clinical trial system is not sustainable and actually will not be able to evaluate in an effective and economic manner these kind of interventions we're talking about here today. So I think that's wonderful. I mean, I believe that all healthcare should be patient and consumer-centric and should be arranged around their needs, not around the needs of the healthcare system, which is crazy. So you have an ideal setup, and other folks are doing this too, to test interventions if you are willing. What you need to do, though, is figure out the interventions. But your measures that you record, and that's what I was referring to in my talk, have to be standardized in a way, and they should be validated. So you need to make sure that your measures of physical function and well-being, whatever you're doing, are reliable, that we know what they mean. And so that's probably the most important thing. And then you're a walking, opportunity to test some of these interventions.
Thank you. Any guidance will be appreciated. Thank you. Zan. Thanks.
So we'll have the last two questions, then we'll be moving on to another exciting session.
So Joan Mann from RestorBio. Janet, I don't know if you remember, but RestorBio is a spin-out of Novartis, and we met with you in 2014 to say, how do we develop a drug that's targeting aging? And so we ended up looking at whether we could improve immune function in the elderly and decrease respiratory tract infections. And it's interesting because we've been working with the Division of Virology and actually have a phase 3 trial ongoing to see in not sick elderly, can we prevent these by boosting antiviral immunity? And so it gets to all those issues you're saying. It has to be safe, and what is the benefit that you're giving, and is it important to elderly people just decreasing respiratory tract infections? Do you also need to show hospitalizations? One of the things that you had mentioned, though, that in 2014 is the thing that you cared about was that you might decrease multi-drug resistant development, even just by decreasing colds, and that would be very important as a public health. So that gets a little bit different than, is that important to that patient, or is it important to society? So it's just curious what you're thinking now.
Well, I think thinking hasn't changed. That's very important to society, but it's not how drug development is conducted, right? It's on individual benefit, generally speaking. Even vaccines, you got to show, but the herd immunity is probably one of the most important things about vaccines, right? So we certainly hope this kind of intervention is helpful. And frankly, again, although human beings are very altruistic, to get somebody to take, people won't exercise, right? And they won't eat healthy diet. So to get them to take an intervention every day for the rest of their lives, you got to have something in it for them. And it has to be something relatable.
Yeah.
Stephen Goff, Novo Nordisk. It was really just more of a comment, Janet. The first was that my understanding in this area now is that maybe what you're looking more towards, or you might be looking towards in the future, is moving away from RCTs to more pragmatic trials where you're able to take in multiple endpoints in larger populations and larger data sets. That was just my sort of observation or comment on my interpretation of what I think you're saying.
No, I think randomization is going to be very important here, that rigorous design. But you can do a pragmatic trial and randomize, but you don't have to have all the other bells and whistles, particularly if you're not dealing with an NME or dealing with known compounds.
Yeah, sorry, that's what I meant. But Richard, this was a new area to me, and I would love to just ask you the question about senescent cells, and what do you think their normal function is in normal life, and what's the safety concerns if you take them out?
Well, I alluded to just one example, perhaps the best defined, that was in wound healing. So that's skin wound healing in an animal model, where administering the same drugs which lyse senescent cells and have some of the positive impacts I've mentioned actually delays wound healing. And the notion may be that senescent cells, even with their secretory phenotype, which we call pro-inflammatory, may have a positive effect, and that one example, and who knows how many others. It's just the usual caution as we're getting into a new area of molecular intervention to be aware of both positive and negative potential outcomes.
Right, nature put inflammation in for a reason.
Well, thank you very much. We'll now move. We'll now move to a session on geroscience.